And Tim, you want to introduce Aaron?
Sure. Aaron Running is one of our long-term members, I think almost from the start. And his wife is behind him there. Danielle has been a great support for Aaron over these 20 plus years. He's been dealing with trigeminal neuralgia. He's come up with something interesting with his camera, which he feels might be helpful to some of our members in trying to explain their pain to either their doctor or their family members who may not be understanding when we don't walk around with a cast on our face, or so he's offering to meet. I'm sure he'd fly out to Northern California with you too to see you, but he's offered to offer this process that he's developed with our members. It would have to be probably more the local people for you to be able to get together at a mutually agreed upon place. So I'll turn it over to Aaron. More description was in the cover note. I won't go through all that and bore you with that. But go ahead.
Right. Well, thank you, Tim. I'll start sharing my screen. And okay, more stuff came up here that I gotta say from the beginning. Here we go. What we're going to discuss was thermography of neuropathic facial pain, which is using an infrared thermal camera to contrast the neuropathic facial pain on one side of the face versus the other normal side. The facial pain may present as either cooler skin temperatures or warmer skin temperatures, which may indicate the underlying dilation of vessels under the skin or vasoconstriction of the vessels under the skin, which may be resultant of the neuropathic pain or the numbness. And like Tim was saying in the email, the purpose of this is to aid patients or aid them in initial diagnosis and most importantly, validate the patient's pain complaints for their doctors or family members that may not understand this very invisible and disease, and of course avoid misdiagnosis and unnecessary irreversible procedures, mainly tooth extraction. We've got a lot of people that have teeth extracted, and of course that didn't impact their pain at all. What we're going to be talking about is my pain, and my pain is atypical and typical, which is more recent. But the thermography is going to be used for mostly atypical type facial pain. But I'm also eager to try this out with classical trigeminal neuralgia patients. And what my facial pain looks like is, I wish I had a cursor here, but to point. I don't know. Can you see my cursor?
Yeah.
I have it in the left side of my face, and it's in all three branches. Oh, that goes back and forth. My constant pain is in my forehead, and I also have numbness there. Constant pain in the cheek, and numbness there, and also constant pain and numbness in the jaw. But then also I do have lightning strikes in all three branches. And you can see it down here on the other side, on the same left side, just another view. So just remembering this this slide, that my left side has the constant pain in all three branches, and you're going to see that on the next slide as a thermal image. And what I'm thinking here too was shocks, I think, are too fast to show up on a thermal image unless there's some type of underlying either pain or numbness that might be apparent on a thermal image. Let me explain the scale here on the left side of the screen. This is the temperature scale for the colors that you're seeing on my facial image. The white is the warmest, and this is near 38 degrees C. And then as you go down here, it's going to be cooler. The red is cooler, the yellow is cooler still, and so on, down to black, which is 24 degrees centigrade. And so you'll notice my left side, the forehead, the eyebrow, is much cooler than the right-hand side. This is the right-hand side. My cheek is much cooler than the right-hand side. And even my jaw down here is cooler. And I'll discuss the lines on the next slide. What these are temperature lines that I've taken a temperature measurement from this point all the way down to the bottom of the line and so on, from my eyebrow through the cheek down to the corner of my mouth. And on this slide, let me explain the scales and what you're seeing. This is temperature with the warmest here at the top and coolest at the bottom. So it goes from 33.8 degrees C down to 30.5. And then on the x-axis, this is the line that's from my eyebrow through my eye, through my middle cheek, and then to the corner of my mouth. And you'll see that my eyebrow is much cooler, which is what we saw. And there's a good temperature difference between the right and the left side. The green line is my right-hand side of my face, and the orange is on the left side. Then as we progress up, the eyes are nearly identical, which is kind of what you'd expect. But then my middle cheek area, it's a much greater temperature difference. Then as we go down to the corner of my mouth, the temperatures are nearly identical.
Is your worst pain in the middle cheek?
Yes. Yes, I think it is. My ATN pain, the constant pain, is worse in the middle cheek, around my I guess it's right below my orbital bone.
Yeah.
The pictures are over your words. Anyway, go ahead.
Yeah, I can't see. Let me try to fix my screen here because I can't see the top of the
You're covering
my screen. Am I covering it?
Yeah.
With this part here, you see that as well?
Sounds like you're in
No, I said you're discussing the words. You just can't see them on the screen. That's all right. Yeah.
There's no words on this screen. There's just the graph.
Oh, okay. Sorry.
That's okay. The next slides here are showing the similar temperature scale. 38 is the warmest, 24 is the coolest. And this is a picture of my right-hand side versus my left-hand side. And this also shows up, the left-hand side rather is cooler than the right-hand side. Also, notice the jaw areas. The right-hand side of the jaw more in the teeth area of the cheek, of the skin area, or skin temperatures rather. The left-hand side is much warmer than the right-hand side. And again, I took temperature measurements that go from the nose through the cheek to the ear. I'll move on to the next slide. And again, this is the nose temperatures, and then through the middle cheek, the right-hand side is much warmer than the left-hand side. And then as we get closer to the ear, the temperatures are similar. Let me see. I think that's all I have to share. That was it. I'd like to go back to this one. Does anybody have any questions or want to talk about if you have any questions about thermal imaging or what we're talking about today?
Aaron, I'm just curious if, since the majority of your pain or the most painful area is in the middle division, your maxillary branch, have you tried using a heating pad or these little hand warmers, and then seeing if that affects obviously it'll bring the temperature up, but does that help your pain? Because it sure helps mine. It gets more circulation going, gets the toxins out of there. It just helps.
Yeah.
So when it's really cold, even putting my hand on my face, or a scarf, but more like the warm body temperature of your hand, or a heating pad, or these hand warmers. I was curious if that has helped you.
How do I say it? I guess when I was first having problems, I was using ice and packing my left side of my face to get relief. But then I did try, here's a plug for Jeff Morton at Pain Free Life Centers. I did try his high dose laser therapy, and that helped my facial pain quite a bit. The high dose laser therapy stimulates blood flow, but that was the only thing that related to heat helped my face pain.
A heating pad did not help you at all?
No. No.
Okay.
No.
So Jeff's heating helped during the procedure, but not continuing?
Yeah, I decided to stop because I started getting shocks. Okay. And I wasn't sure if anything was related or not, but I don't think it was. I was getting a lot of relief from the high dose laser, but again, I wasn't sure if one was causing the other.
Right.
I wanted to get the shocks figured out.
Yeah, those are the worst for sure.
Well, I'm taking more Tegretol as of about a week ago, and that's helped me quite a bit.
Good. You look like you're a lot more comfortable.
Yeah, I feel better.
Yes.
I'm starting to get shocks now, but my brain pauses. I think it's from the Neurontin.
I think we can all
Tegretol's improved my pain, my shocks a lot, and then reducing the gabapentin on top of that. I was at 800 4 times a day, and now I'm at 400 3 times a day. That's helped my brain pausing, but apparently it's still pretty bad. I'm struggling for words.
We didn't mention that Aaron has a motor cortex stimulator installed. He's had that for how many years, Aaron?
I can show a picture of that. Just real, let's see here, in the appendix of this. This is, it's up in the right-hand side of my head. And the electrodes are literally on the dura of the brain. And then the wire runs down the right-hand side of my head and my neck under the skin. And then I've got a battery in my chest, the signal generator. Yeah.
That's very interesting that you note that your wrists hurt only during breakthrough ATN episodes.
Yeah. Yep.
Very interesting.
It's like a burning numbness in my wrist. Preferred pain.
What is the motor cortex stimulator for?
It works the best. It's for my ATN constant pain.
Okay. Okay.
I have a question.
Sure.
Go ahead, Anita.
Aaron, my husband, Gene, also has ATN. He's had it for 12 years. And he only recently got the shocking pains. I noticed that you mentioned that happened to you later also.
Yes.
The motor cortex stimulator, how similar is that to the peripheral nerve stimulation? My husband had that in 2020. The wires were put on the V1, V2, and V3, and the battery in his body. He wound up in screaming pain and had to have it taken out.
Oh, wow.
I'm wondering how similar is what you have, the motor cortex stimulator, to what he had.
Okay. His is on the peripheral nerves, I think, after the ganglion. So it's on, I think they're on the V1 and V2 and V3 branches.
Mm-hmm.
And mine is on the brain.
Okay.
On the dura of the brain.
Okay.
It's on the surface. It's not like the Parkinson's deep brain stimulator.
Mm-hmm.
Those penetrate, of course, through, and they go into the spot to control the tremors. This is what mine is on the surface.
Okay. And have you found it to be helpful?
Yes. Oh, yes. It put me back to work.
Okay. Okay.
Yeah.
So, I wonder if that is an option for my husband. He just he just had Gamma Knife, and it was only 2 weeks ago yesterday, so we haven't gotten any results from that yet.
Okay. It might be an option.
Mm-hmm.
And
I've never. I'm sorry.
Dr. Brown was his surgeon, so you met with Dr. Brown too, didn't you, Jean and Anita?
Dr. Robinson in Atlanta, Dr. Jim Robinson.
Okay, I thought you met with Dr. Brown on telehealth.
No, we never did get around to doing that. Yeah,
because that's who put Aaron's motor cortex in.
Okay. And we've never heard of the high dose laser therapy either. Who did that for you, Aaron?
It was Jeff Morton, Morten.
Okay.
And he's the one who started up it's called Pain-Free Life Centers.
Okay.
I'm not sure if they're national.
No, they're just local.
Okay.
Oh, okay.
Yeah.
Because I remember Jeff saying that the high dose lasers that he uses are the only ones around, and that he's the only one that's using it. So I'm not sure if it'd be good if it'd be worth contacting him.
Okay.
He's in Southeast Michigan.
Okay.
Got a number.
Thank you.
I'll send it right
welcome.
to you, Jean. And
Great.
Okay, thank you.
Great. Thank you. Thank you, Lynn. Okay. And thank you, Aaron.
What
Oh, you're
medications?
welcome.
What medications is he on now, Anita?
Well, he has the pain pump, and in the pain pump, he has Dilaudid and fentanyl. And then he takes oral medication, gabapentin, 600 milligrams up to 4 times a day. And then he takes oxycodone, 20 milligrams up to 6 times a day.
For breakthrough.
He's taking all this stuff at once?
Yeah.
Is the pain pump helping at all?
Yikes.
Not right now, no. And actually the pain medication is not working. That's why we tried the Gamma Knife, and we're waiting on that to work.
I have a question. That's what I wanted to ask. So the Gamma Knife, that was what the neurosurgeon was recommending for me. So there was not success with the Gamma Knife, Anita? Is that what I'm understanding?
Well, they did warn us that it would take between 2 and 12 weeks, and it's only been 2 weeks as of yesterday.
Okay.
So we still have some time, you know. But yeah, that they told us it would take a while. They said between 2 and 12 weeks or even longer.
Yeah, the reason for that, Marie, is that it forms scar tissue, and the scar tissue blocks the pain signals from getting through. So it takes a little while for the scar tissue to form.
Okay.
We're hoping.
What caused Jean's facial pain?
We have no idea. It started 12 years ago, just out of the blue. We had one neurosurgeon at Emory in Atlanta who said he speculated that it was his chronic sinusitis that brought it on. He's had chronic sinusitis for years. So it's really idiopathic. They don't know. They don't know.
Have they offered oral morphine at all?
You know, only in hospice. And of course, I hate to say it, but where we are here in Georgia, I don't know how it is in other places in the country, but in order to get any amount of pain control, he's actually been in hospice twice, and we're in the process of trying to get him in right now to bridge the gap until hopefully this Gamma Knife will come through and work. But it's hard to say that. I wish I had the strength and energy to advocate and really get out there and talk about this. But the only way to get real pain control where we are is to be in hospice.
And that worked, right?
In hospice, yes, they were able to get his pain under control, and mainly with the liquid morphine. Liquid morphine under the tongue.
Oh, okay.
You know,
the CDC just loosened their guidelines. You should look at them. They're right there under your nose in Georgia.
I saw that. Yeah, they're right here under our nose. But you know, good old Georgia.
Yeah,
we're about as corrupt as they get.
It is so frustrating when you know what you need, they know what you need, and you just can't get it. Right. Well, especially him being a vet, and it just kills me. We've had palliative on board for the last 3 weeks. They've been trying to do some things, but haven't been successful. And they're the ones who are recommending the hospice right now. I'm so sorry you guys are going through so much.
Gosh.
Can't take
That's
a run
really
at veterans
terrible.
again and see if they'll loosen up, huh?
Pardon me?
You can't take a run at veterans again and see the new guideline?
I would probably go a different route than I have in the past.
Go to Emory before veterans, yeah.
Well, no, because Emory, believe it or not, is also very anti-medicine right now as far as pain medicines go, narcotics.
Anti-opiates, huh?
Yes. Emory is, the VA is. In fact, the VA doesn't even do pain pumps. And of course, you know about the big fight I had with the VA over that.
Yeah, yeah.
Mm.
Let me just wrap up with Aaron real quick, if you don't mind. Does anybody have any other
Yeah.
questions? So Aaron can stop sharing the screen and we can get more faces up.
Yeah.
There's one. Oh, go ahead. If
No,
there's
go
any
ahead.
more questions.
Go ahead,
Has anybody, did you have a microvascular decompression surgery or a MVD surgery, or has anybody suggested that? Is there a neurosurgeon in your area that does that? I believe there's Susan. Susan's on here somewhere. Susan, isn't there somebody in the Atlanta area that does that, that's known for doing that? But have you had that surgery?
He's not had it, but we discussed this with Dr. Jim Robinson. We had been to Florida, also to Shands, University of Florida, several years ago, asking for that. The neurosurgeon there would not do it. Dr. Robinson wanted to try Gamma Knife first, and I did ask, is this completely off the table, microvascular decompression? And they said, no, it was not. Completely off the table. So I don't know, that might be, we've been, if it's there, we've done it. My husband's had ketamine infusions. He's had Botox. He's had, the PNS surgery. He's had the pain pump. Now he's had the Gamma Knife. He's tried CBD oil. He's tried THC that we were able to get. He got licensed in Georgia. We've been the gamut. He's had stellate ganglion blocks. He's had other nerve blocks. It's just, you wouldn't even believe it.
What about the percutaneous rhizotomy?
We went to a surgeon in Tennessee, in Nashville, and he refused to do it. He said he might wind up in worse pain.
Yeah, yeah.
See, none of those things
Anesthesia.
none of those things deal with the source.
Hang on one second. Let's just wrap up with Aaron so he can stop sharing, and then we can.
Okay.
Hang on a minute. Go ahead, Aaron.
Okay. Well, what I'd like to do is, if anybody was interested and help me gather more information and more thermal images, if you could call or text me, because I'd like to take more pictures of folks with atypical TN, and I'd also like to take thermal images of folks with TN, classical, just to see if there's a difference.
Are you in Detroit?
Yes, Rochester Hills, Michigan.
I'd certainly be willing to do that, Aaron.
That'd be great.
Yeah.
Aaron, can anybody hear me?
Yes, Laura, go ahead.
Thank you. Aaron, I'm so sorry to hear about your pain. I actually teared up when you said you have it. I also have ATN. I've had it for 9 years. And my bad spot is the same left side. It's right here. And I get the electrical shocks down my cheek and my jaw. Where yes, I get both. And I freeze. I freeze and I just collapse to the floor and I can't move. I also saw Jeff, and I went to the pain-free life centers for about 4 months, and it was really wonderful. It was like instant pain relief, and I would walk out. I would walk out of there. Would walk in with like a pain of a 7 out of 10, and I'd walk out with a 0. But the 45 minute drive home, it would already come back. So
man.
I would do this, and as you know, it's very expensive. It's thousands of dollars.
Yeah.
Got to sign that contract for X amount of treatments, and I kept doing it for months. But eventually, I kind of just gave up, and we were even looking into getting my own device for home. And so I went on to Anita and Jean. I'm so sorry. I went on to stellate ganglion blocks at University of Michigan with Dr. Wade Cooper. I did that for 2 years. I ended up, failing that. Then I went on to Botox. I failed that. I failed Neurontin, gabapentin, all that. I failed so many medications.
Laura, make sure when you, I just want you to know you didn't fail. You didn't fail any of those things.
Right.
They failed you. It's not you.
Right.
It's important that we have the right self-talk, because because that really affects so much of how to survive. I've had
Yes.
ATN for 25 years or something like that, in all three branches on the right side. And we're in this together. We have to help each other. And I'm so glad we're all talking about the reality of it for us. It sounds so easy to go try this or that, but then when you try everything one after another, it gets exhausting and expensive and depressing.
It's exhausting and it's depressing every single waking moment. Yeah.
Is that,
So,
is
we're
that,
here for
Marie,
you, Laura.
is that Marie talking?
No, this is Laura. She's
I
I
can't.
did. I
Oh, let,
I emailed you quite a few times.
Oh, Laura Bomber?
No,
Please
Laura,
stop sharing. Is that okay?
yeah, would you please? That'd be great, Darren. Thank you.
Laura Pilkey,
There
Tim.
you go. Thank you.
Oh, yeah. You're up at Prudenville, right?
Yeah.
Well, yeah, but isn't Dr. Mounayer, you saw him recently?
I did. He's awesome. He just really, he's changed my life. I was
good to hear.
Yeah. I wanted to talk to Anita because and Jean, I'm so sorry. Everything you listed, I mean, except for the Gamma knife, they left it up to me to do it. I'm a registered nurse by profession, unfortunately.
So am I. It's
Unfortunately,
panacea.
the pain and the medication, I'm not safe to work, and that was my purpose in life, and I had my dream job, and that was taken away because of the pain. So I'm not allowed to work anymore. But that is something, it's really difficult to live with every day. But they gave me the choice, and honestly, I did the research, and it's just it does more damage than good, in my opinion. And so I started seeking out alternatives, and I have tried literally everything. And Aaron, I wanted to suggest you look into red light therapy. And I did red light therapy, 8-9 years ago, and it did nothing for me. It was like a light bulb, a flashlight. Let me tell you that the advances in the LED diodes now are far above and beyond. I truly,
Interesting.
it is. And I have like 4 books on my shelf over here. I truly believe that red light therapy is like medicine of the future, but I have had almost instant relief with red light therapy. And I have done so much research because U of M, the director of neurology, Dr. Wade Cooper, Dr. Charles Schultz, Mayo Clinic. I've gone to Dr. Bose at Mayo Clinic, and no one can do anything for me anymore. I literally am like at the end of the road here. So I'm 46 years old, and I have 2 twin daughters that are 10 years old, and I have a lot more to live for. So I'm trying to find my own path, because I'm not taking, you can have Norco or this for the rest of your life. Like, that's not good enough for me. So I keep researching and looking. And so I've had really good results with heating pads and ice. Like, that is a joke. It does not work. When I also have chronic persistent migraines. Mayo Clinic in Minnesota diagnosed me with, I have ATN. I was diagnosed 13 years ago with ATN. I was blessed with the fact I had it for 9 months, and I went into remission for 5 lovely years. And in that time, I got married. My mom, unfortunately, was diagnosed with stage 4 uterine cancer, but I got to take care of her while she was dying for 1.5 years. And I was healthy and well to be there for her for every appointment, every chemo, every radiation, everything. And a couple years went by. I lost my father 6 months prior to my mom. And then I was so afraid that the ATN was going to come back, just with stress or whatever. It never did. And then I got pregnant with twins, and I just thought, oh my God, it's going to come back. And it never did. And then I was walking into a 12-hour shift at Hurley at night on a November evening, on November 13th, I remember. And a cold gust of wind just hit my left cheek. And I just fell to the ground going to punch in. And that was it. That was it.
Oh my God.
And it's never left in 9 years. So anyways, red light therapy, I have some suggestions for Aaron or anyone. I have done a lot of research. I have a lot of books, and I have a lot of tools at my bedside that are helping me. I'm going to Earth Labs in Traverse City. They have PEMF therapy that I'm doing that is helping. I do IV. Jean and Anita, you said your husband did ketamine. I've been doing ketamine IVs every month for the last 2 years. I have ketamine. I have ketamine troches every night. I have them. Does Jean have ketamine troches that he gets every night?
No,
We're not familiar with.
we're not familiar with.
So
I'm sorry.
Oh, you go ahead.
He had how many infusions did you have? 4 or 5?
No, it's 7. But
he had 7 infusions, and he never did get any relief. Did we just not go far enough with it, you think? Or?
Relief.
Yeah, I mean, you got to keep going. I think you got to keep going. He didn't.
Expensive.
I know mine is $300 out of pocket. I mean,
yeah, every time it's 300 here too.
333.
Yeah. But I get instant relief. Like, I have zero pain when I get it and when I leave, but I feel like the bottom of a taxi cab floor because you get Versed and you can't go and do anything. And you're just, but my God, like, I cry every time because I literally remember what it feels like to be a normal human being. And then, my body is so upset and irritated and angry from that infusion for 4 to 5 days later. I can't move out of bed for that long. But then I have a sweet spot of like a week and a half where I have decreased pain, where I can actually have more time with my kids and actually go outside, and the wind on my face doesn't bother me, and I can do things and I can pretend to be a normal human being. So it does give me some benefit. And I, like I said, I've been doing it for 2 years now. It did stop during lockdown and COVID, and that was horrible for me when it stopped. But there is ketamine troches that you can get. So a troche is basically just a wax square of medicine, and it has to be made at a compound pharmacy, and it's refrigerated, and it's just a little square, and you stick it under your tongue or in the cheek of your mouth. I take it every night after dinner, and for an hour to an hour and a half, I get complete pain relief. But I'm dizzy. The room's moving a little bit. Jean, you know what I'm talking about. After you got that, my God, yeah. Oh my God, like, it's just, you can't describe what the ketamine does to you. So you can't move and like physically go shopping or go do anything, but you get every day. And so I'm guaranteed that pain relief with my troche every day, and I'm just grateful for it. So Jean, you can look into that, where you at least
Thank you.
Oh my gosh. Yeah. And then there's also, I have ketamine nasal spray. That's PRN. Now the troches are daily. I get one daily, and there's 75 milligrams, Anita. So you can, in the troche, it's TROCHE.
Okay.
What's the source?
What's the source?
Where do you get that from?
She said that you have to have it compounded at a compounding pharmacy.
Yeah, you need a script from your doctor, like whoever your neurologist. It would be your neurologist. Whoever writes you your medication, like your oxycodone medication, your doctor who takes care of you for your ATN.
Okay.
And you would have to build a compounding pharmacy. Yeah.
Okay.
I also have nasal spray, ketamine nasal spray. That's PRN. Now that's very short-lived. That's not anything that gives you long lasting, but that is from my electrical attacks, something where I need very quick relief, where this is what I describe it as. I get sucker punched by like an invisible force on the left side of my face. I don't see it coming. There is no warning. And I just immediately start crying, and I go to the floor, and I have many times projectile vomiting. And it doesn't matter if I have food in my stomach or nothing. I just I have bile, and it's very violent vomiting. And it takes a lot out of me. So that's when I for the nasal spray, and it would be like instant bringing it down from a 9-10, and it brings it down to a 3 or 4.
Laura, not to interrupt. I thought Dr. Mounayer tried a new med on you. No?
He did. He just did. I just started. Well, I wanted to go back from what I was doing. But yeah, he did. And it has changed my life. He started methadone, which I'll be honest with you, as a nurse, I was totally against, and I would not fill the med for like 3 days. I'm embarrassed that I'm actually taking it, because you have to understand my experience with the word and the drug methadone, because as a nurse, my specialty was premature babies in the neonatal ICU. And that was my passion. That was my purpose in life. And I worked at Hurley, downtown Flint. And so we saw a lot of worst of the worst. And most of our babies were drug withdrawal babies. And a lot of them were methadone. And it was horrible. And I had to push, IV morphine to these babies, and their vitals would be sky high. Their skin would be purple from screaming, and I could do nothing to soothe them. And the IV push morphine did absolutely nothing. I could do nothing to soothe these babies. They were in so much pain and suffering from their mothers taking so much methadone. And so you have to understand that I was like, when he suggested that on my initial consult, I was just like, no, this, I am totally against it. My Dr. Schultz at U of M suggested Suboxone, and Dr. Mounayer said, why would he say that? That's for people who are opiate addicts. And I said, I think he just doesn't really know. My doctor now, he's honestly, not to be rude, he's really just good for refills, and that is it. I asked him to help me find a pain clinic, because he said, you should go to a pain clinic. I have to help you. I have nothing else to say. And I said, well, can you at least recommend one? It means something when I said, you're a neurologist at U of M, right? Can you at least tell me where to go? And he said, just Google it. That's what he told me. So thank God for Tim recommending Mark, because just Google it, really.
That's I know.
So anyway, it's helping you.
Yeah, so it is. Oh my God. So I'm sorry, I'm just meeting you for the first time, Jean and Anita.
Yes.
You guys, would you be against trying a very low dose of methadone?
No, because he has been on methadone one time in hospice, and it helped him. And we had just been talking to the doctor about that again.
Yeah, it helped me.
Yes.
I'm not a doctor, and I don't pretend to be, but I honestly, I don't think any good can come from the Gamma knife. I feel like it's radiation, number one, and I feel like it does more harm, and I just think there's more.
Laura, they just had it. Can you be a little sensitive there, please?
Oh, I'm sorry. Sorry.
He just had the Gamma knife, so I'm just saying, he
just did have it. Yeah.
Oh.
I apologize. What I meant is to continue on with the treatment. I didn't.
Okay.
I meant
got you.
Okay.
Yeah.
No harm, no foul.
No foul.
There's other alternatives that are less invasive as well.
Right. Right. Yeah. Well, so you feel like the methadone is helping you?
I do. Yes, very much.
And I believe it helped Gene. I really do. When he had it, that was in 2019, I believe. That was the last time he had it. And you know what was so sad? When he came out of hospice, that was to have the peripheral nerve stimulation surgery done in early 2020. And they made him get off of the methadone. Made him get off of it. Would not let him stay on it. Sent him to a methadone clinic. That was one of the most difficult.
It was titration.
Difficult things that we've ever done. We were going to a clinic, and I don't mean this in any offensive way. I think God was really dealing with me personally about my pride. I'll just be honest with you. My husband was a pastor. I was a pastor's wife. And they sent us to a clinic where all these precious people who had been on drugs were on this stuff, trying to get them off. And I was really mad at God. I said, we don't belong in here, Lord. And I tell you what, the Lord took me to the woodshed. And he let me know I was no better than any of those people. And if it were not for his grace, that could be me. And so I learned a big lesson there. It was a tough walk.
I'm sorry, Anita.
Sorry.
It's a hard struggle. Your hubby's trying to comfort you, sweetie.
I'm so
But
sorry.
we got through it, and it was God really did some amazing things in that time in our life. He really did. We were able to reach out to some other people that were hurting.
Oh my goodness.
But he was forced to get off of it. He was forced to get off of something that was helping him. And thankfully, this pain doctor that we have now, and I know what you're talking about with trying to find pain doctors. He's the pain pump doctor that we have now. And he's very open to trying that with my husband and not forcing him to come off of it if it does help him. So
do you happen to recall, I know you've been through so much, what dosage he was on last time of the methadone?
My goodness, I wish I did remember that.
20,
it's been
20
what,
something 20 comes up to my mind.
Yeah, I it's been since 2019, 2020. I don't recall the exact dosage, but they slowly titrated him up in hospice, and then of course back down, after that when he got out of hospice. So but I could try to get that information and get that to you somehow.
No. You've got enough on your plate every minute of every day. I was wondering, but I'm just trying to help. I meant no harm.
We didn't.
I think if just with my experience and what I know has worked for me, I understand everyone's different, and what works for me is not going to work for you or anyone else. But to try it, I think methadone and possibly the ketamine troches, to at least try it, it's a good start.
Right.
Okay.
Yeah. I mean,
and what about
just I'm not telling you, it's just an advice of a potential.
Oh, yeah.
Well, Dr. Mounayer will be on shortly, so we'll be able to let him explain from the medical side how he approaches methadone.
And the red light therapy, has that also, you said, been very helpful?
Red light.
Yeah.
No.
Yes. I lay on it. It's right here. It's like my best friend. I take car. It's a belt.
Okay.
So you can plug it into the wall, but what I really like about it is that it comes with a wall plug, but it also has like a USB, so I can take it in the car.
Yeah.
And then, I put it on the side of my face where it hurts the most, and then when I have ATN pain, which is just all here, but when I have, sometimes I have the ATN pain plus the chronic migraine too. So sometimes I just wrap the belt literally around my whole head, and just feel it goes. It just feels, it goes so deep. It's just like a warm hug that just takes the pain slowly away, and it's just, there's just like nothing like it. It just works so well. It is rather expensive. It's like $189, but it's on Amazon, and I paid for it. Like, I mean, we pay for so much all through the years trying to get better. But if you have the Amazon store card, you can anything over $100, you can pay on over 6 months, you know, with 0 APR. So that's what I did.
Excuse me.
Okay.
I hate to interrupt, and this is such an important conversation, and these are troubling, your challenges. These are heavy things you all have going on right now. We're going to have to table this soon. Dr. M will be in very shortly. I just want to make sure Aaron's wrapped up sufficiently, and we want to thank you so much for your presentation. And once Dr. M is done, the questions answered on, we can go right back to this. But I'm sorry to interrupt. I know we're on a clock on the other end.
No worries. Nope.
No worries. Yeah.
The hearing what.
Aaron, some closing statements you want to make before Dr. M pops in?
Well, the thermography, there's a lot of research already that's been done in the past, and there's a American Academy of Thermography or Thermology that has if you check their website, they have a way of getting hold of people that have the ability to take thermal pictures of your face, or actually any part of your body that has like, let's say, neuropathy. One hand is colder than the other hand, or vice versa, or similar with feet and those kind of things, circulatory things. So that's another place. American Academy of Thermology, or Thermography, I can't remember which one it is, has if you type in your zip code, it'll give you a list of people that are near you, if there is one. The closest one to me is in Ohio, so there's not very many people that do it, but it sounds like people here. I mean, if you have an initial diagnosis, you know what you're dealing with, then this is not for treatment, of course. Okay, and that's all.
Well, thank you so much, Aaron. Any other questions for Aaron? Oh, Melody has a question.
Yeah, I just wanted to say, Aaron, I live probably really close to you, and if there's anything I can do, just let me know, okay?
Okay. All right, thank you.
You're welcome.
Thank you very much.
Yep.
I think you have mine from before, Aaron.
Yes, I have yours. Yep.
And Donna.
Yours showed definitely warm area for where your pain is, because you have the infection in that's deep in your bone, and it's still showing up as warm there.
Thank you, Aaron.
All right. Thank you all very much for having me and listening to me.
Thank you.
Thank you.
Thank each of you. May God bless each of you, and He will. Through His Son.
Same to you.
Eugene.
Thank you kindly. I received that.
Okay, we're going to see Dr. shortly.
Yeah.
We can resume whatever we want to talk about. We'll go right back to Julie and Anita talking. That's great. I didn't mean to interrupt. I just want to make sure we close out.
Oh, no worries. We're good.
What level is your pain, your husband's pain, Anita?
Honey, what is it now?
7.
It's a 7 now, and it's been running a 7, 8, 9 most of the time.
Yeah.
And the ice and heat does not work, as someone did say. Ice and heat does not work.
Well, let me clarify ice and heat, guys. It's not that I'm on a lot of other medications. It just helps bring the blood circulation. It's not, I'm not saying it would be satisfactory alone by any means.
Oh, yeah.
I'm
but
on a ton
yeah.
of medications and procedures as well. So,
he still does it. I mean, he still tries it. Bless his heart. He freezes it till his face is numb, basically. Yeah. Mm-hmm. Oh,
you've been a wonderful caregiver, Anita.
Oh, thank you, dear. Thank you. I'm sort of running out of steam, but this is helping me tonight. I'm encouraged.
Oh, good. It's
Right.
nice to be in community, isn't it? It's important.
Yes.
We fight together.
Yeah.
Together.
I'm glad we could do this tonight. He's been in so much pain most of the time we haven't been able to do it.
Yeah. We're glad to see you both too.
How soon will you get into hospice?
They are working on getting all the. Hey, Miss Donna.
Hi, how are you?
How are you? I'm wearing the bracelet. See,
Oh.
the Proverbs
Yeah.
3:5. Yes, I wear.
Close to us.
Yes. So, they are working on getting all of his documentation. They're also trying to get a written, I guess it would be, what would you call it? A doctor's order, I guess, for the hospice. And they're trying to get it from his pain pump doctor. So I've been making a lot of phone calls trying to coordinate all of that.
And he can do that at home, right?
Yes. I'm a little scared, and I will tell you why. The first hospice that he was in did great. They titrated his up, but then the second one,
Make it as concise. as
y'all may
possible.
remember the second one within 2 days had almost killed him with morphine. They gave him too much. So I'll be watching him like a hawk this time.
Is that intravenous?
No, it was under the tongue, but they were giving him way too much.
They were adding a patch.
And they had a fentanyl patch that was maybe a 50. Was it a 50? That was before he had the pump, though. So there wouldn't be any patch now, I don't think, with the pump.
Okay.
Yeah.
I'm very disappointed with the pump.
Yeah.
That's too bad, Jean. That's so frustrating.
Yeah.
Looks like Dr. Mounayer has joined us.
Oh,
Okay.
great. Fantastic.
We'll wait to hear from him. There he
Is
is.
that Mark?
Mark,
Well, there he is. So before Dr. M begins, just again reminding everybody this meeting is recorded to be published on YouTube. And if anyone wants to stop the recording at any time, just please raise your hand or click on a reaction button or send me a chat. I'll do my best to stop it. We want to encourage all the questions you all are sharing. It's been a great evening so far. And you're not only blessing the group that's here, your questions will bless people down the road who view this video. You just have no idea. There's so much information out there in this challenging, these maladies you all share. So with that, I'll turn it over to Tim.
yes, we have for the first time with us Dr. Mark Mounayer, who's an interventional pain physician at Michigan Orthopedic Surgeons. He'll talk more about his location and his availability. I've been with him now. It's been a year since last November, since Dr. Pepler was diagnosed with ALS. Luckily, one of our members, Kim Boynton, remembered that this group was helping some of our other members, and he's been a godsend to me and about 6 or 7 of our other atypical trigeminal neuralgia patients, as Laura talked about a few minutes ago. So, Doctor, I'll let you start without any more introduction.
Well, thank you for that introduction, Tim. Can everyone hear me well?
Yes, thank you so much.
Yes.
For
Yes.
joining us. We're
We can hear
Thank
you.
you guys for having me. It's a privilege to talk to you guys. I'm going to open up my presentation right now. Can you guys see it okay?
I just
Yes.
made you co-host now, Doctor. So I just authorized you to be co-host, and now give it a shot.
Can you see it now? It went away. I went to go click on the thing you sent.
Oh, I'll send it again if you need me to.
Yes.
No, it says you're still legit. I'll remove it and put it back in.
Okay, let me go back to the.
Bear with me. I haven't done it yet. Hang on. Okay, here you go again.
Okay. So can you guys see this presentation?
Yes, we
just see you.
Yeah.
see you.
Okay.
I'm gonna,
It's open
Aaron,
on my computer. Let's see. Share screen. Maybe I have to click
I'm
share.
You need to share screen. Yeah.
Yeah. Okay. Share
Right. Yeah.
desktop 1. I'm assuming that's it.
Did Aaron stop sharing? He's used.
Yep. We
Okay.
got it, Lynn.
Thank you.
Do you see it now?
No.
No.
Okay. Let me try the share screen. Multiple participants can share simultaneously. Yeah, let me put it on that.
Not working for me.
Here, let me click Microsoft PowerPoint. Open some preferences. Interesting. Okay.
The green around it.
Yeah.
Who can share? It says host only. I can't make the selection. I don't know why it's
I don't either.
Do I need a?
I just took you out as co-host. I'm going to turn
Okay,
you.
good.
I'm going to apologize for this. I'm going to make you co-host once again. Let's try this.
you are the co-host now.
That's what it says. It should say that because
Yeah.
it shows here your co-host. So now you should be able to share.
It says that on our side, but it doesn't do it.
Not working.
Interesting. Share screen.
The wonders of technology.
Oh, some of the truth.
Yeah.
We have to learn sign language, I think.
That's virtual.
Get out of
Yeah.
Sure.
I apologize for whatever I'm doing.
Okay. Let me try this.
The multiple screen thing could be your problem. I'm not sure.
Right. You don't want that.
Okay. Terry knows.
Let me this
Terry's
may-
our new tech.
Here.
She's our new tech.
No.
Here we go.
No.
Starting.
She was right.
Starting.
You are.
There you go.
There you are.
There it is.
Oh, cool.
Yay.
Pretty cool, right?
Right.
Yeah.
Cool.
Fantastic.
Yeah.
You're
This is
showing
awesome.
up in the corner. That's cool.
Yeah, it's my background now. Wow.
It is cool.
It was worth the wait. This is pretty high tech.
That's right. You're bigger than life now.
Yeah.
Wow.
This is better than I thought. Okay. Wow. Look at this. So thank you for that introduction, Tim. I've had the privilege of meeting Tim and about 7 other patients from the support group. You guys are all awesome, and I enjoy working with you guys. I see you guys about 5 to 7 visits a year, and you guys have taught me as much as I've been able to hopefully share some information with you guys. So I just want to start with a little introduction. So I'm a medical doctor. I got my Bachelor of Science at University of Michigan in Ann Arbor in BBCS, which is biopsychology. Continued for my School of Medicine at Wayne State University in Detroit, Michigan. Completed an anesthesia residency and then a pain medicine fellowship at a combined Wayne State School of Medicine, Detroit Medical Center residency and fellowship. I went on to become board certified in both anesthesiology and pain medicine. I also work as an editorial reviewer for the Journal of American Academy of Orthopedic Surgeons. So I've been in private practice now for 4.5 years, and I actually just got recruited to leave my current job and join the biggest and I think the best orthopedic group in Michigan called Michigan Orthopedic Surgeons. They have multiple offices throughout Metro Detroit, all the way from I think Sterling Heights, Shelby Township, all the way to West Bloomfield, a couple offices in Troy, Southfield, and Bingham Farms. So, you know, they treat all types of orthopedic injuries, spine, hip, shoulder, knee, wrist, elbow, trauma, pediatrics, they have everything. So they recruited me and another physician to start their pain management division. I start there January 1st, 2023. I'm being given kind of the reins to run this practice the way that I want to run this practice. So I'm going to be able to, you know, I'll touch base on those new CDC guidelines that came out this week. I'll have more autonomy with telemedicine services. So I'll be starting off kind of in the way here in Southfield, Michigan. And I'm starting to see patients. I'm going to be telling all the patients that I currently see. So I'll be informing them at our next visit. So I don't want this to come as a surprise. But anyone out there in the Michigan area, I'm happy to start seeing you as a new patient after January 1st and in Southfield, Michigan. And as many of my patients here listening tonight know, I'm always available to my patients 24/7. Here is my cell phone, and that is my new office number, and that is my email address for work. Any questions, you guys can feel free to reach me. Having said all that, enough talking about me, let's talk about what we came to listen here tonight. So how can I help you? I want to start off and make it very, very clear that I am not a TN, ATN specialist, medication-wise or procedurals. There are some doctors out there, and I've seen some of the past speakers you guys have, ranging from neurosurgeons to other types of proceduralists who can treat with various different types of procedures your pain. And I really think that's incredible. My training has been mainly in pain management of the cervical and lumbar spine. However, I do treat numerous patients with various conditions with medication, and I'm able to sometimes point them in the right direction to a neurosurgeon for an evaluation for any procedure. I perform about 1,500 to 1,800 procedures a year, mainly, like I said, in the lumbar and cervical spine, epidurals, medial branch blocks, rhizotomies, SI joint, hip, knee, and whatnot. My main focus and specialization is spinal cord stimulation or neuromodulation for patients who failed back surgery, have inoperable back pain, CRPS, inoperable back pain being scoliosis or other comorbidities. So having said that, I treat the pain that my patients describe to me, and I give them some options that they may have not been told about by either previous pain physicians or their primary care doctors. And I like to just give patients different options. So I want to start off by saying that it was kind of instilled in all of our brains in medical school that if you're reading a board question, one of the board exams in order to pass medical school, and you get a question about trigeminal neuralgia, that you can basically stop reading the question and circle the answer. Because it's almost, as we joke and call it a knee-jerk reflex. You circle carbamazepine and you just move on to the next question. So does it work for everyone? Absolutely not. But this is clear as day, known as the gold standard of management. There's been two basic mechanisms of proposed action for the medication, one being the sodium channel inactivation by changing the frequency of the action potentials, and another is one directly in the synaptic transmission. If you are a support group member, I assume you've tried this, but if you haven't, you should call a neurologist tomorrow and start this immediately, because this is, like I said, the gold standard, and I just want to make sure that that point is stressed. So initially, 100 milligrams are given by mouth twice a day, conventional or extended release. There's also a suspension for up to 4 times a day with meals. This is slowly increased. The maximum dose is 1,200 a day. That's a cumulative dose. Most patients typically are on maintenance doses of 200 to 400 milligrams at a time, twice a day. So that would take you to either 400 or 800 cumulative. But like I said, the max cumulative is 1,200. There is a different formulation, Carbitrol, that I wasn't very familiar with, but it does have different guidelines. In case you are on that specific medication, that may be why these numbers may sound a little foreign to you. So one support member that I treat had initially, I think, been on carbamazepine, but it had been many years since he's been on it. And, you know, I did tell him and encourage him to see a neurologist to see it. And there's kind of a reason why I don't prescribe it. Number one, I've never prescribed it. It's typically done by the neurologist, and I'm a complete outpatient physician. Yes, I do have hospital privileges, but I don't routinely order anything except EMGs, MRIs, and referrals to other specialists. I don't really order laboratory results or monitor my patients with lab values. Carbamazepine needs a lot of close monitoring. It doesn't need to be done every visit, but probably at least once or twice a year. It may increase things like your BUN, so your kidney function tests, liver function tests, hemoglobin, different blood cell counts, your thyroid function test, and it can all, even in younger patients, cause false pregnancy test results. So it's something I just want to let you know, even though I don't prescribe this, like I said, this is the gold standard and something that everyone should, you know, many patients have had this terrible condition that you guys have to suffer and deal with for so many years that maybe they had tried it many moons ago, or maybe something worthwhile revisiting if it's been a long time. So once again, neurologist, the Tegretol, there's also Dilantin. That's something else the neurologist can talk to you about. So something that I commonly prescribe my patients with any type of nerve-related pain injury or just nerve-related pain of undiagnosed or trigeminal neuralgia, CRPS, diabetic neuropathy, peripheral neuropathy is anticonvulsants. So the typical ones are gabapentin and Lyrica. This is another thing that I have had, obviously there's many physicians who do it properly, but one of the biggest things I want to stress to you guys tonight, if you guys have had previous negative reactions or consequences to these medications, is how was this medication actually prescribed to you? Okay. It was instilled in my mind during fellowship that the only way to properly prescribe these medications is to go low and slow. So what does that mean? It's not the most, you know, therapeutic perfect approach, but it's the best way to mitigate side effects and slowly get the medication into your system so that you don't really ever get these side effects. So gabapentin comes in 100, 300, 400, 600, and 800 milligram dosages. I typically prescribe for patients either two options. For patients who've tried it and are unable to tolerate it because of some of the side effects, I ask if one of their side effects was the common one of being like drowsiness or sleepiness. I say, you know what? Why don't we use it for that effect? If they complain of loss of sleep, I'll give it to them QHS, which is nighttime only, and see if they get any relief from that. The most common way I prescribe this is for patients to take it typically 3 to 4 times a day. So a typical patient, I would start them on 100 milligrams and I'd write either 3 or 4 times a day. However, I would have them take it for the first week only at nighttime, second week morning and nighttime, third week morning, afternoon, and nighttime, and possibly doubling up the nighttime dose. 2 months later, I would then bump them up to the 300, have them start taking the 300 at night, 100 in the morning, 100 in the afternoon, slowly replace the morning and afternoon doses with 300. Next 2 months later, bump them up to the 400. I would try to get to that sweet spot where we get some pain relief without any side effects and the patients are doing well. Similar, I've noticed, and it's pretty well studied, that Lyrica, some patients who respond negatively to gabapentin may respond more favorably to Lyrica. Similar thing, I either start at 50 or 75. Lyrica is not dosed as frequent as gabapentin, so it's typically BID or TID, which is twice a day or 3 times a day dosing. And once again, go low and slow, can give significant therapeutic effect while minimizing the sleepiness, fatigue. There are many other side effects, obviously, with these medications. Sometimes they can cause leg swelling and other things. But one of the big things I want to point out whenever patients ask me about side effects is I tell them, do not look up this medication. Do not Google this medication. Any medication you look up, you would wonder how it's even sold, even over-the-counter Motrin. Anything you look up, the side effects are crazy. Why? I'm not saying they're not possible to get. I'm not saying it's not going to happen to you. I'm not saying you're crazy if you get these side effects. What I'm saying is when drugs come out to market, they test them with 10,000 people. Anything these people report, by law, they have to mention as a side effect. What does that cause? It causes very obscure, scary side effects that patients sometimes may read about and be hesitant to try. The side effects are also higher by starting at a higher dose initially. So if you go, if you're seeing a physician who doesn't commonly prescribe this and starts you at 300 milligrams 3 times a day, you may not like it. So by going low and slow, it's a way to get therapeutic effect while mitigating these side effects. Another class of medications that I talk to my patients are tricyclic antidepressants. These I prescribe for nighttime dose. They don't so much help with patients. I mean, they're done for mainly nighttime pain. They don't really help you fall asleep, but they have in studies shown a higher likelihood of helping patients stay asleep. So for patients with a lot of nighttime painful attacks or anything. So there's kind of two spectrums, and these are the most two commonly prescribed, being Elavil, also known as amitriptyline or Pamelor. So, everything has pros, cons. Elavil is a stronger medication, higher chance of side effect. Pamelor is weaker. However, you're going to have a smaller chance of side effect. So everything is a fine balance. They both come in multitude of doses. Common side effects from these are dry mouth, constipation, weight or loss gain, low blood pressure, which is orthostatic hypotension, increased heart rate. The most common one that I hear is dry mouth. But my patients tell me, you know what, it's worth a dry mouth for a good night's sleep. So that's one option for patients. A bunch of other medications. Cymbalta is a SNRI, which is a serotonin norepinephrine reuptake inhibitor. Once again, with this medication, Cymbalta, it's also known as duloxetine. I like to prescribe it in the morning. There's been some studies that have shown that it almost has the opposite effect of other antidepressants like the tricyclics, where instead of making you sleepy, it almost gives you a little pep to your step. So I have my patients take it in the morning. Typically, I start with 20 milligrams. After a couple months, bump it to 30, and as long as there's no issues, bump it up to 60 milligrams. For patients with spasms, there's muscle relaxants. There's kind of a whole category of ones like Flexeril, Robaxin, Xanaflex. These medications all kind of work the same way. Separately, you have Baclofen, which is more, I think, appropriate for spasms. There's a bunch of different topical compound creams I prescribe for some of my patients with neuropathic pain diagnoses. And these topical compound creams can combine things that are taken orally, and sometimes patients are unable to tolerate them orally. And so in a topical cream, they're able to get some substantial relief. There's a bunch of different formulations. I have no financial interest, but I use Biomed a lot. They make a nice cream that gets delivered to my patient. There's a few different concoctions they can make up mixed with gabapentin, ketamine, which I'm sure many of you guys have heard about IV ketamine clinics. There's lidocaine in these creams, Baclofen. There's CBD creams. And then also there's some pain doctors that are not a proponent. I wouldn't really consider myself a proponent, but I find marijuana to be pretty safe. So I don't mind if my patients use it for their pain relief. So there's some pain doctors that won't let you be on prescription pain opioids and non-opioids that are controlled substances and marijuana. However, I find it to be safe, and if it gives my patients relief, then I'm willing to allow it. So those were kind of the non-opioids that I wanted to first talk about. Next, I'm going to talk about different opioid medication. First, I want to talk about the CDC guidelines that just came out. I talked to Tim about this earlier in the week. One interesting synopsis about this is the CDC clearly stated that when they came out with their regulations in 2016, they were intended for primary care physicians only. However, that's not what happened. What happened was primary care physicians just sent them elsewhere to pain physicians. Pain physicians were then targeted. Pharmacies were then targeted. DEA licenses were jeopardized, supposedly. Hospital, everyone, insurance company number 1, 2, and 3 caused the biggest headaches for people. I still get letters every single day for patients on pain medication and to justify why they are on pain medication.
Oh my.
It is intolerable, and I just write back, received, thank you, and I send it back. I don't even read it anymore. The only time I really care is if the patient is on a benzodiazepine, which I will get to shortly. But having said that, there's two main broad categories of opioids: short-acting and long-acting. So that has to do with the half-life of the medication. Also, what I mean by half-life is how it affects you. So if a short-acting medication is something that is supposed to be taken PRN, as needed, okay? So short-acting is for when you're in pain. There are patients who typically use it kind of like on a frequency of hours, which is appropriate. But one big difference is you don't have, you kind of get a peak and a valley. So you're in pain, you take it, you're out of pain or lessen your pain, and then the pain medication reduces itself. Whereas long-acting medication, you get a more stable effect of the medication. So from short-acting, I went from kind of most mild to more potent. You have your Tylenol with codeine, typically Tylenol 3 and 4, that's 300 milligrams of acetaminophen. Tylenol 3 has 30 milligrams of codeine, 4, 60 milligrams of codeine. The next step up would be Tramadol. Tramadol is a nice pain medication. So all the opioids that are short-acting work on the mu, it's called. It looks like the letter U, it's pronounced mu receptor. Tramadol also works a little bit on the serotonin and the norepinephrine receptor. So there's some added benefit from stepping up to Tramadol. Norco or hydrocodone, Vicodin, as it used to be known. Then next up is Percocet, which is oxycodone. These two medications are both combined with 325 milligrams of acetaminophen. Then there's oxycodone, which comes in the same dosages as Percocet, but then if you want to go higher, they ditch the acetaminophen. So once you get to Percocet and Norco, they only come in 10 milligrams. Oxycodone can go all the way up to 30 milligrams. And this is the immediate release that I'm talking about. Then there's Dilaudid, which is more commonly given IV, but it is given for pills in the outpatient setting. And then there's an immediate release formula of morphine. The long-acting, there are other options out there, but I'm going with the most bread and butter, easily authorized medications, I should say. There are some more innovative abuse deterrent formulations that are kind of hard to get authorization for insurance, but the most common being fentanyl, which is given as a patch to be worn every 72 hours. There's an extended release morphine, and then there's methadone for pain. Common side effects of opioids. One of the most common side effects is OIC, or opioid-induced constipation. So one of the things that I really wanted to talk about that is I have a lot of patients who take over-the-counter stool softeners like Colace or Sunna or Dulcolax, Miralax, and whatnot, and some of them, they don't get relief. And the issue is, and the reason behind that is the medications I just referenced are used to treat regular constipation. The patient who doesn't have constipation other than on opioids doesn't have a gut motility issue. They have an issue with the opioid blocking the mu receptor in their gut. So there are some special medications out there that are used to prevent the opioid from binding in the gut and allowing for regular bowel movements. There are some that are maybe not so effective, but more easily covered by insurance. And then there's some that are obviously hard to get authorized. These are very expensive medications. Without insurance can cost anywhere from $250 to $400 a month, but there usually is a formulation, and I work with my patients to get these approved eventually. One of the biggest so having said the thing earlier about the CDC, one of the big things that the pharmacies, insurance companies really care about right now is concurrent use of opioids with benzodiazepines. So benzodiazepines are Xanax, Klonopin, Ativan, and Valium. Okay. So in 2016, the Federal Drug Administration came out with a black box warning of being on concurrent opioids and benzodiazepines. In each individually slow down your breathing. Together, it's a synergistic effect. So, 1 + 1 isn't 2. They're saying 1 + 1 = 4. So everyone gets very spooky and scared to write pain medication with patients on these medications, as there's a higher risk for respiratory depression and, as the CDC will tell you, sudden death. In addition, there's just common, it can cause sedation, urinary retention, confusion with any of these medications. Another thing that I want to talk, a lot of patients get scared about is they misuse these 3 terminologies, or maybe they're trying to describe one that is not one of these, and maybe a different one. So a lot of time they want all the patients to me, I don't want to be addicted, or is this, and when they ask me a question, does this mean I'm being addicted? So there's a big difference between tolerance, dependence, and addiction. Okay. Tolerance is human nature. Okay. When you take something for long enough, you develop tolerance to that medication. There's only 2 ways that I know of to help break or stop tolerance from happening. One is either to increase the dose or increase the frequency of the medication. So either the milligram dosage per medication or the frequency you're taking it. Another is to do an opioid rotation. So if I have a patient on Norco, I'll switch them eventually to Percocet, and then Percocet back to Norco, or vice versa, to help break that cycle from happening. Another one is dependence. So dependence is the thing that gets most confused with addiction. When you're on something for a long time, if you stop it and you don't feel well, it does not mean you are addicted to it. It just means your body is used to it. So if you take something and your body has adjusted to having bowel movements or, perspiration or anything, when you're on something for so long and you stop, or you miss a dose, or you ran out, or anything happened, you're not addicted to the medication. It just meant your body became more dependent on it. And then there is addiction, of course, and addiction is, addiction. So you guys all know what that is. That's, alcoholic addiction, everything. The last concept I want to talk to you about, and it's something I don't really talk to many patients about, but it's something that you'll see some literature on, or if you hear your doctor talk about, is opioid-induced hyperalgesia. This means that, so everyone's body makes a chemical called dopamine. Dopamine is a chemical in your brain that gets produced in order to make your body feel better in cases of pain. The thought behind opioid-induced hyperalgesia is being on pain medication for a long time, and for patients who always feel like they're not able to come down, or when they do, they have more pain, or they're always in 10 out of 10 pain. Sometimes these opioids, what they do is they send a negative message to your brain to not make dopamine. So your body isn't capable of healing or making itself feel better during pain. When that happens, it kind of senses your body to a heightened level, and it's unable to help itself. So it's kind of like the opioids are causing, it's not that they're causing more pain when you are on high dose narcotics for a long time, and this doesn't happen. This happens in a very minority of patients. They can develop periods of pain that are harder to treat because their body can't help itself in addition to pain medication. So I just want to talk to you guys about kind of a combination that I've seen work for a lot of my patients. My personal favorite combination is to use methadone or another long-acting agent, sometimes along with a short-acting opioid for breakthrough pain, and in addition to that, an anticonvulsant for pain relief. Tramadol, Norco, Percocet for breakthrough pain 1 to 3 times per day, with methadone or morphine every 12 hours, along with gabapentin and or Lyrica. I find this approach can help some of my patients dealing, this is from a medication standpoint, once again. I want to make sure my patients have either tried or considered any procedure that you guys have had previous speakers talk about. And then once again, I want to stress that I hope everyone has tried Tegretol or carbamazepine first, or at least if they haven't in 20, 30 years, given it another shot, because they may be surprised that it helps. So I kind of move the screen here. Okay. One thing that I want to talk about is methadone. So I have one patient in the support group that has had tremendous success with this medication. I just saw her last week, and we had a very touching moment. She described some relief that she didn't think was possible. So, and I've had other patients try it and not have the same success. So it's just something I want to bring to your attention, why I like methadone a lot for pain, especially the type of pain that you guys have. So all opioids hit that mu receptor that I talked about. I did mention briefly that tramadol has some other properties to it, but methadone works on the mu receptor, plus it works on the NMDA receptor, which is what ketamine works on. So it's the only oral non-ketamine compounded medication that's not over the counter, but easily available from a local pharmacy that works on the NMDA receptor. I'm an anesthesiologist, and ketamine is known as the most complete medication known to mankind because it provides analgesia or pain relief. It produces a lot of positive effects on the body. It doesn't cause any respiratory depression, and it's got one of the longest half-lives, methadone. So methadone helps patients who suffer in continuous pain get adequate pain relief without having the dips and the valleys.
Wow. Okay.
So it's very effective. It's very inexpensive. There's no active metabolites. Its clearance is not influenced by any kidney problems or hepatic problems. So there's no active metabolites, unlike morphine and other medications. However, I have a lot of patients, as soon as I say that word, they say, "Doc, I'm not a junkie," or "I don't abuse drugs. Why are you bringing up this to me?" Or they think I'm trying to label them. So methadone clinics are not what I'm talking about here. I'm talking about typical patients. The one that I talked about the other day, she's on 5 milligrams twice a day. So that's 10 milligrams in a whole day. Some patients I have 20 milligrams twice a day. So that's 40. I don't usually go much higher than that or need to, but I am willing to in the right circumstance. Methadone clinic, they have to go every single day and get 80 to 200 milligrams of methadone. This is completely comparing apples to oranges. And I give 30-day supplies at a time, up to 2 months. So, just some final thoughts here. Carbamazepine, Tegretol, first, second, and third first-line option. Make sure everyone has tried that. We discussed the anticonvulsants, the gabapentin, the Lyrica, the antidepressants like the TCAs, Elavil and Pamelor, and Cymbalta, the SNRIs, cream, marijuana, other holistic options. we talked about the opioids, the long acting or the short acting, and then without a doubt, dealing with such a painful condition day in and day out, this support group is definitely an invaluable resource to all of you guys. I'm happy to, any other day, that's my cell phone. That's my new office number starting January 1st. I'm happy to treat anyone. Just mention Tim's name when I see you. I'd love to talk about Tim and the whole group. That's my email address if you're more inclined to communicate via email. So that's my little bit of presentation. Sorry I had to do it later. I have 2 young kids and a long day at work, so I just needed to unwind a little after work. But I'm glad I could talk to you guys tonight.
Thank you so much.
Thank you so much.
Thank you.
We appreciate it.
Thank
Appreciate
you.
your time.
I can't
Appreciate
believe
it very much.
My pleasure.
you are so sincere in giving out a personal cell phone. That just brings
Yeah.
tears to my eyes. You understand, and that's just
Yes.
it's all. That's what we need. Someone that will understand.
Wish
Yeah.
wish that he could help down here in Georgia.
Can you guys hear me?
Yeah,
Yeah.
can we turn off the sharing, Doctor, so we can see each other?
Do you know anybody in the Atlanta area, Doctor?
Are they turning that off?
I can do it from here. I just wanted.
Yeah, just
I didn't
Very
want to be rude. I just wanted.
is that better?
Yeah, that's perfect.
Thank you.
Can you hear me?
Yeah.
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 Okay. I do have patients that have moved out of Michigan and I've helped them. However, I've never initiated care on someone not living in Michigan. So if you're willing to drive here for your first visit. I have a patient that I just saw yesterday from Virginia, and then there's someone who left and moved to Tennessee. She comes back twice a year to see me, and I do telemedicine visits in the meantime.
Fabulous.
She does obviously have some family here, both of those people, so they're not just, they're making a trip out of it to see some family, but one's in Virginia and one's in Tennessee.
Okay.
Not with anything you guys are dealing with, more just chronic back and neck issues.
Yeah.
Okay.
Will
Yeah.
one of your scripts be filled in another state?
Yes, we've had no issue. I mean, it was kind of an issue prior to COVID, but since, if there's any blessing that COVID brought us, it has been the ability for telemedicine to get to patients that are in hard to reach areas. Also, they've kind of relaxed their guidelines. The one in Tennessee I've been treating now for 18 months down there. And I don't know what's happening, but the pharmacy may be giving her a little bit of a problem because they said she may need to find someone closer to her house. But I did vouch for her that she still comes, and I still do random urine drug screenings and whatnot. And I maintain her, check the MAP system, which it's called here in Michigan. Every state has a prescription drug monitoring program where you're able to find if the patient is pharmacy shopping or doctor shopping to do some stupid things, as I should say.
Yeah. Amen to that.
So I didn't really talk about anything, maybe that you guys haven't heard about tonight, but maybe just to clarify some points that maybe you guys had, or, bring up some medications maybe that you've had some negative experiences with, and maybe it wasn't prescribed to you properly, or something you haven't tried in a while and maybe willing to give it a try again.
Marie, why don't you talk about Tegretol? You started way in the very beginning. You could. You had a question on that for Lynn.
I didn't hear that. I'm sorry.
I was taking 200 milligrams twice a day of the Tegretol, and my doctor wanted to increase it to 300 milligrams twice a day because initially, before the Tegretol, the pain was caused from smiling, talking, eating, wind, the whole gamut. And since going on the Tegretol, I am able to finally smile again without pain and eat and talk. I'm very thankful for that. And but the only thing that's causing me pain now is the cold wind. And so she knew that the winter was coming, so she wanted to try increasing my Tegretol. And when she increased it to the 300 milligrams twice a day, I noticed I was getting flu-like symptoms. I was getting severe muscle weakness, nausea, and headaches. Is that I've heard other people say they're allergic to Tegretol. Was that the symptoms you were getting, or were you getting a rash? How did you know you were allergic to the Tegretol?
I turned into one great big hive. I started out with a rash that looked like measles in the middle of in my core. It spread toward my feet, toward me, and I literally was one big hive from chin to toe.
Okay.
I had the same thing happen.
Oh, okay.
So they took me off it and put me on gabapentin.
Okay.
But I thought Tegretol was a miracle.
Yeah.
Oh, it is, because
but then
I was up to 3,600 milligrams of the gabapentin, and it wasn't helping. And
then you need to be on something else.
Yeah. Have you tried Lyrica?
Pardon?
Have you tried Lyrica?
Well, as soon as they put me on the Tegretol, within 2 weeks, I noticed an improvement. Okay. And the longer I've been on it, the better I've felt, to the point where, like I said, now I can smile again. And I mean, even driving in a car would bring on the pain. But now it's just the cold. So I've just bought a bunch of hoodie jackets, and, I've learned to protect my face, because now I can finally touch my face without it producing the pain.
Where do you live?
In Michigan.
Need to get you down south.
I just came back from Florida last night. So
hurricanes don't help either, though, do they, Murray?
Pardon?
I said the hurricanes don't help either, though, do they?
That's why we came back early. We were supposed to come back Saturday, but
talk about
hurricane brought us home. So
are there any more questions for Mark? Thank you very much, Mark.
My pleasure. Thank you guys for
having me.
Thank you.
Thank you so much.
Thanks a lot.
Thank you.
May God bless you.
Thank you.
Thank you.
Thank you.
Well, he was terrific.
Yeah.
Yeah, I was glad to hear that about the methadone again. It's like, this is so interesting to me that we've been discussing methadone with our the palliative and with our pain pump doctor. And then to hear, is it Laura that we talked to?
Yes.
To say that it had helped her. So, and then to hear him say, that's great.
Yeah, and
it's interesting. It's interesting to see people from different parts of the country, because in Northern California and with the group in Southern California, we've even seen them in the same groups. Nobody is talking about methadone, are they, Susan?
Nope.
Nobody has mentioned methadone.
No, our M word is marijuana.
And gummies, they get gummies online. Or, of course, you can go on any street corner and there's a dispensary here. So, marijuana is very easy to get, but marijuana, of course, has other problems, and THC in particular. And some people found THC to be very, very helpful, but THC has other issues. But nobody has mentioned methadone.
No.
I know, and that's what's so frustrating. And I know that this pain doctor we're seeing now, the pain pump doctor, is the very first one that we have come across who is willing to prescribe it for pain.
Wow.
That, because generally speaking, from what we understood, it was to get people off of narcotics.
Right.
But it works well for some people's pain. And I know when we were in that methadone clinic, when he had to be titrated off of it, when they made him come off of it, there was a gentleman there who said it was the only thing that had ever helped him, and they were making him come off of it too.
Oh, that's so frustrating.
That's awful. When somebody's getting pain relief, to have to. I was given naltrexone at Stanford. I probably should have asked the doctor about it. I'm just going to look it up. I don't know if that's methadone or not. I believe it's a drug to help addicts, with their addictions too. It didn't help me. It made me crazy, but, I'm just throwing it out there, naltrexone.
Traxone.
Naltraxone, I think. I'll look it up here in a second. Stanford's real big on giving that out right now. They're also big on the ketamine. And I did 2 days of ketamine infusions at Stanford after I had a failed rhizotomy. And it made me really, really sick. I was supposed to do the 2 days, and then if I could tolerate it, go into the hospital for 5 days and have it, intravenously for 5 days. And my son was like, no way, you are not doing that. But caveat here with all of us, some things work for some of us and don't work for others. It's crazy.
Yeah. It is.
It's crazy. I also have the naltrexone nose spray. I just came home and took some because we were talking about it. It doesn't help me at all.
Oh.
Did you get the ketamine nasal spray, Susan?
Yes.
Does that help you?
No, I haven't. I just came home. I had a little bit. This was my last thing that I've tried because there's another volunteer support group person who was using it and she was saying that it was helping her. So I don't know if you guys can see it, but here's my,
around too fast for us.
Here's my mom. Yeah, it makes me crazy.
Some people have weird side effects,
What about
I've got 100 milligrams.
What about the gummies, Susan? What about the gummies? Have they been
helpful
at all?
I saw Hal was on earlier. I think
he left and then he left. Hal was the one who and Hal is from New Jersey. Wait, where is he?
Atlanta. Hal's our buddy from
He's in Atlanta now, but he's from New Jersey. And how he found us in Northern California, I have the same way we found you, I suppose. But he was the one that recommended gummies. And marijuana gummies.
I got them. I have to go back to my medicine cabinet.
but he bought them online, and Susan said, "Hey, I'll try some of those." So I wondered if you had tried them.
So Hal's 80 years old.
Yeah.
And he's got me taking gummies.
With some gums.
And he's originally from New Jersey, so if he comes back to your group, he's a kick. So here are the gummies. I got them from the company that he got them from, which is down in LA. The company is BINOID. And I got them, and I came home one night, ready to open the bottle up and take one before bed, and I could not get the cap off the bottle. They have this mega kids thing. So I called them up, I go online and I get on their chat and I'm like, how in the hell do I gotta have a gummy? How do I get the cap off? I can't get the cap off. And they're like, they're chatting back and they send me to
I'm running over with the car or something.
Exactly. I'm getting the hammer. They're telling me to take a knife. I'm like, are you kidding me? I'm going to chop my fingers off. So, to make a long story short, I think I finally used like a screwdriver and something
never
to
put the safety
pry it off.
on.
And then they sent me a free bottle because I was in such distress. I've been taking one at night. Pardon me?
Without the safety cap.
Without the safety cap, right. Well, this one's got a white one. It might be easier to get off. I don't know. This one was a black one. It was like a nightmare.
So funny.
So
did
did you
it work?
actually try it, and did it work for you?
Oh yeah, I've been
Does it just make you hungry and tired though?
Yeah, you know what?
That's all that happened to me. I got hungry and tired.
I was taking them before I went to. Hal told me to took half of one. Well, I took a whole one, and I've been taking them now for maybe the last 3 weeks, and I didn't know if they were doing anything because it takes like an hour and a half for them to kick in. And so I took one earlier to see if they were having an effect. And unfortunately, I go right to the refrigerator, and start eating. I get the munchies.
Hungry and
they
tired.
do make me sleepy, but for the pain, I can't really say they're helping. They're helping me for the pain.
I know.
Damn, right?
Damn is right.
I know. It's like there's nothing.
Well, Hal said they did help his pain. They did help. They helped him. They helped his pain, and they helped him
and
sleep.
Passes out, Terry.
Well, that's it. He couldn't sleep because of the pain, and they were helping him sleep.
And you know what? If we can't get our sleep, that increases our pain.
Nothing.
Tenfold, 100-fold.
Right.
One thing that's helped me sleep is Seroquel, 50 milligrams at night.
Okay. Spell that.
Yeah.
Spell that.
SERQUEL, I think.
Yeah,
Say that again.
QUEL.
Yeah,
Sero,
it's got a Q in it.
SERO.
Type it to the group there and
Okay.
send it out in the chat.
Let me look it up to make sure.
And this is for sleep, right?
Here it is, Seroquel, SEROQUEL.
Okay.
And it is, what's the generic name?
Give me that here, Doug.
Quetiapine.
Yeah, that's it.
Right.
Thank you.
Yep. See if I can.
It's it's like it's for bipolar schizophrenia. So the Tegratols and the carbazepines, right?
Yeah.
Must be in that category.
Tim, are you still there?
Yeah, right here.
I got a question for you, if you don't mind. It's about Dr. Mark.
Yeah, I was going to say, I'll be calling Melody and Aaron in the morning about how we transition.
Yeah, because
to the new location.
I got a
what's up?
big question about that transition because it's kind of messed me up a little bit here. So
No,
if
I'll
I
talk
can
to you.
talk.
I'll
All
talk
right.
to you in the morning.
Okay, thanks.
Yeah.
Thanks, Tim.
Yeah.
Well, it sounds like telehealth is an option, which is good. I do all my visits on telehealth.
We try to do a lot of ours on.
Yeah, they're just refilling scripts, basically.
Yeah.
That's good.
Tim, while I'm thinking about it, I can't think of his name right now. I saw him post something the other day. He had to have a kidney transplant.
Oh, you're talking about Dr. Casey.
AC.
Yes.
His
How
liver.
is he doing?
His liver transplant.
Liver.
He celebrated his birthday. He's doing fantastic.
That's
Did
wonderful.
he get one? Did he have
Yes,
a
he got
transplant?
it.
Yeah.
Yes,
He did?
That's great.
Yeah.
it was the husband of a TN patient who Dr. Casey had helped.
You're
Oh.
kidding.
Is that not a godsend?
In Michigan?
Yes, in Michigan.
Oh.
They had to do it. I think they had to go to Pennsylvania to do it.
Pittsburgh, yeah.
But
You know
he was-
what? I'm going to send him a get well. Has it
Oh,
been a
he would
while?
love that. He would love that.
He would love that, wouldn't he?
Yeah, he would love
Yeah.
that. Yeah,
Yeah.
everybody was praying for him and his family. And
So
I went
how
out to
long-
lunch.
How
What?
long ago was it?
Oh man,
Been a couple of months, hasn't it, Lynn?
Yeah, a few months.
definitely a couple months.
So it's new.
Yeah,
Yes.
I took
He hung
his
in there.
I took his daughter to lunch, and she was just so thrilled. They've been through so much hell.
Oh.
A couple of years, and he was so near death. That was terrifying. How
Oh,
close he
you
got
know,
to-
I have been afraid to reach out to you guys because
Yeah.
I just didn't want to hear bad news. I
but it's fabulous news. He just had a birthday.
just saw him on a
Yes.
post something on one of the Facebook groups.
Yes,
And I was
he
like,
was.
oh my God, I knew I was going to be
amazing.
on this. So
Yeah,
I,
I'm glad you joined.
That's just great
wow.
That's
Karen,
great.
I grew up in Michigan, so all these
Yes.
hospitals everybody's talking about, and Bloomfield Hills and
and he had lunch with
Detroit
our
and
kids.
Beaumont Hospital and
I know welcome
right where
anytime.
everybody is.
Oh, that's awesome.
Well, I grew up in Ohio, so
Oh,
There
well,
you
there
go.
you go. You know how
We're
to shovel snow.
But can y'all tell I was born and raised in Georgia?
Oh,
Yes.
no, we
Yeah.
can't tell it all.
No.
We might just have to
That's-
indoctrinate you up here, guys. You may have to become Michiganders.
well, and that was one of the things about oh shoot. Who recommended the gummies, Susan?
Hell.
Oh, that was one of the things about the Hal. The first time I talked to him and he was talking about being from Atlanta, I said, Hal, you're not really from Atlanta, are you? You don't talk like you're from Atlanta. He said, no. He said, no, I'm from New Jersey.
Oh, that's good.
Laura, sorry I overlooked you. I'll call you in the morning too. Laura,
What's that?
I'll be calling you in the morning too. I
Okay.
overlooked you about the
No.
transition.
Thanks, Tim.
Oh, I thought you were talking. I'm sorry. I had to go check on my kids. I just wanted to let you guys know I'm going to sign off because my kids have school in the morning, and I just wanted to say thank you for letting me be a part of tonight's meeting, and I'm just very grateful to have met you guys and listened to your stories, and I definitely feel your pain, and I know I have empathy. I understand, and it means a lot to me, like just to know that there's other people out there that understand, because you feel so isolated and so alone. And people say that they understand, but they just don't. And unless they actually felt it, but to have people that actually go through it, it means something. And it's just,
You know what it's called?
Yeah.
You know what it's called? Misery loves company.
Yeah.
Right?
Yeah.
Well, right?
You're going to raise those little girls of yours, Laura, and they're
Laura.
going to amaze you. They're going to be the kindest, most compassionate people the world needs right now.
Laura, we were glad to hear your story, and we feel your pain.
Yeah.
We feel your pain.
Yes.
I will each one of you in my prayers. I swear, I promise. I pray every single night. And
Me too.
Jean and Anita, if you have any more questions for me, please feel free to. Tim's got my email.
Okay.
So he can give it to you. And I stepped out just to check on my daughters, but I heard someone say something about sleeping. And I missed the conversation. I just got the end of it. And again, I'm not a doctor and I'm not here to tell anyone to take this or take that, but I have not slept for years. I get maybe 2 to 4 hours of sleep. I want to sleep. I'm exhausted, but when I go to lay my head on the pillow, it just is so painful. I can't. So I have to sit up and then try to keep myself busy, and I go and clean and organize, but I'm a zombie, you know? So I've tried Remeron, but that is just horrible for me personally. And it made me have the night sweats where I literally, like, my nightgown was like I went through a sprinkler, and I would change it like twice a night. It was just terrible. And the side effects, weight gain, but that's all I had. And I did that for a very long time. However, my Lexapro that I've been on for 13 years, it's really not working anymore for I have, as you all know, suicidal thoughts and ideations. If not every day, every other, like it's part of my daily life. It's,
You're not going anywhere. You've got 2 daughters.
But they deserve a mom that's normal and healthy.
You are normal and healthy.
You're the best you
Just
can
normal
be.
and healthy with pain, and we're gonna all figure this out.
And
Yeah.
Lauren,
You are teaching
Laura-
your kids how to beat adversity, Laura. You are doing so many things to raise your kids in such an amazing way. You don't see it now, but you're building some strong daughters.
You are.
And Laura, thank you for what you contributed tonight, because it was really helpful for us too. And you're just a beautiful person. All of you are.
Thank you very much.
Yes.
Well, make
Laura,
sure you talk to Dr. Mounayer about increasing that if you need it.
No, I will. No, it's been a godsend. The suicidal thoughts have stopped since the day I started the methadone. I'm so
good.
Oh wow.
Yeah.
That's good.
Yeah, so since my Lexapro for depression stopped working, and the Remeron was causing me so many problems, but it was like the only thing that would literally help me sleep. I ended up, long story short, getting a new medication for depression, but bonus for me, it actually helps you sleep. They said it helps you sleep. And so I wanted to share that with you. And I'm not saying it's going to work for each one of you, but it's Topamax.
I've taken that.
So who are you? Okay. Does it work?
I've taken everything. Can I just, while I'm thinking about it, I'm 65 now. So I always say when something pops into my head, if I don't blurt it out, you'll understand when you get to be my age, Laura. When something comes to your head, man, you got to blurt it out. You got to interrupt or it's gone. Are you still taking?
But I'm 46, so my memory and my brain fog is real from the pain and the meds.
Absolutely.
And I feel like old every day. So from
I just say one thing? The ketamine. Are you still taking the ketamine?
I do ketamine IVs monthly, and
that's right. You said that. It impressed me.
It
really made me depressed. I'm wondering if the ketamine, the infusions.
No, I do not have that issue at all. And
I don't think that's what's bothering you.
No,
okay.
It's not. No, and I take troches. No, the depression is totally related to the skull crushing vice grip pain in my left lobe of my brain. Absolutely.
Okay.
But I take ketamine troches daily, and I have ketamine nasal spray that does work for me in emergency type situations. But the Topamax, it's not only for depression, but it also, I take it at night. I started off with 1 pill for the first week, and I take it 2 now, but it's killing 2 birds with 1 stone. It helps with depression, but oh my gosh, I have never slept. I sleep like a baby. And
good.
Whoever was asking about medications for sleep, And I know, part of TN and ATN is depression. Literally, it just goes hand in hand. It has to. When you're in pain, I mean, my God, we fight and struggle day. So,
Yeah.
but dopamine, it does both. It's a depression, but also it's given me the best sleep of my life. So I just want to share that. But
Thank
Thank you.
Yeah.
Yeah.
That's
hopefully
great.
you guys next month at the next meeting. But thank you all for it's been
Thank you, Laura.
Yeah, thank you, Laura.
Thank you.
Thank
Get
you.
those baby girls for us.
I will.
Bye, bye, Gigi
We're
and
rooting
Anita.
for you, Laura.
Thank
Yeah,
you.
we're rooting for you.
Appreciate it.
I'll talk to you, Tim. I'm going to sign off. I'll talk to you tomorrow, okay?
Yeah, all buzz you guys.
All righty. Bye-bye.
Patience of-
I need
God
to
bless
check out
everybody.
too,
Bye,
because I have
Terry.
bless
other
you.
Good
things
night.
to
Thanks for
do.
joining
But
us.
thank you
Goodbye.
all very, very
Thank
much
you.
for
Thank you.
inviting us.
Yeah.
Thank
Yes.
I
you for
really
inviting us,
appreciate this.
Southerners as well.
Yeah.
Appreciate
Yep.
your
Goodbye,
group.
everybody.
Okay.
Yes.
Thank
Yeah.
you, Peace
Bye, Terry.
and
All right.
Lynn
Nice Sherry.
Bye-bye.
and Tim.
Bye-bye.
Dan, how's your granddaughter?
Yeah.
Grandson. He's
Son,
13 minutes.
grandson.
Grandson.
13 months, and they're coming next week. They got
Yay.
They're still out here in San Francisco?
Yep, they're still there.
Yay.
And, yep, not for
Oh,
forever.
wait a minute. Is she in San Francisco?
I am.
My brother lives in Benicia.
Oh, my best friend lives in Benicia. I'm a half an hour from Benicia.
I know. I
goodness.
know.
Yeah. I'm up in the wine country.
Okay. Well, yeah. I know
Yeah.
my brother lives there. He and his family have been there for years.
Oh,
Lynn
I know Benicia very well.
Lynn,
Yeah.
Lynn and Pete, enjoy that grandbaby.
Okay, thank
I
you.
see you next time.
See
Yeah,
y'all.
send a
Everyone.
picture. Send
Okay,
a
I
pic.
will.
Okay.
All right.
Bye-bye.
Thanks for joining us, Cheryl. We
Bye.
didn't get to hear much from you. Is Kip doing good?
Hey,
Yeah.
you're muted, Cheryl.
Can't hear ya.
I know. I'm gonna.
Can't hear ya.
Kip is good.
She's got
There,
her
mute.
stuff on.
There I go.
Can
There
hear
you
you.
go.
Oh,
Can you
there
hear
you
me
go.
now?
Yeah. Kip
Yeah,
okay?
he's good. We are blessed. Yes.
Oh, good. You're both doing good. You look wonderful. Thanks
Oh,
for joining us.
Thanks.
Thanks.
No, I wanted to hear your speaker.
Yes, he was very good, wasn't he?
Yes.
In
Yes.
fact, that orthopedic practice is excellent. Tim and I are both patients there, and Pete went there too. So he treats a lot of hurting people.
Yeah. I actually, I wanted to tune in for some other people that I know